and welcome to a brand new season of the RRR series from StudyMEDIC. And we usually bring this out before the exams in small videos which are highly useful for your exam preparation. And today we'll be covering a very short but a very high yield topic for your Part 1 exam, and we'll be covering Inguinal Region from the Anatomy module. So the commonly tested questions in this topic are mainly the contents and the hernias, applied anatomy, and we will be focusing on what the examiners really want you to know. So before we begin, we always begin with a motivational quote, and today's message is something that I really believe in. So results require a routine. So this is a new RRR. And what I really want you to understand is that results really don't define you. This is an exam and the preparation requires consistency. Every small repeated effort is shaping the result that you are all working towards. So here's wishing you all the very best as you are approaching your exam, and we hope that our effort in bringing you this series is also going to be helpful for it. In brief, the learning objectives for today's session will be to identify the boundaries and the surface anatomy of the inguinal region, to basically know about the inguinal canal and its contents, and of course its clinical significance, to differentiate between indirect and direct inguinal hernias, and to understand what and where are the deep and the superficial inguinal rings, understand the relationship of the nerves, vessels and facial layers within the inguinal region, and also apply it to the various SPA questions that are frequently appearing in the exam. So let's begin from the beginning, and let us try and understand what the inguinal canal is. So it is an oblique passage in the lower abdominal wall, and it is around 1.5 inch or 4 centimeters long. It runs just above the medial half of the inguinal ligament, and it allows structures to pass from the abdomen to the groin. And let's go through the boundaries of the inguinal canal, which is extremely important for the exam. So let's talk about the anterior wall, which is formed mainly by the external oblique aponeurosis, and laterally it is reinforced by the internal oblique muscle. The roof is formed by the arcing fibers of the internal oblique and the transverse abdominis muscles, which form the conjoint tendon. So the roof is formed by the conjoint tendon. The posterior wall is formed by the transversalis fascia throughout the length, and medially this is also reinforced by the conjoint tendon. It is here that the deep inguinal ring, which is a weak spot in the lower abdominal wall, is present. The floor is formed by the inguinal ligament itself, with the lacunar ligament contributing medially. So that completes the boundaries of the inguinal canal, and a useful mnemonic to remember it is the MALT or MALT. So the roof is constituted by two M's or the muscles, which are the internal oblique muscle and the transverse abdominis muscle. The anterior wall is formed by two aponeuroses, which is the aponeurosis of the external oblique and of the internal oblique. The lower wall or the floor is by two ligaments, which are the inguinal ligament and the lacunar ligament, and the posterior wall is the two T's, which is the tendon, the conjoint tendon and the transversalis fascia. Next, let's talk about the contents of the inguinal canal, which is another exam favorite, and we will specially emphasize on the female inguinal canal and the contents which are present therein. So in females, the main structure passing through the canal is the round ligament of the uterus. So we must know that the round ligament is attached above at the uterus and it extends till the labia majora. It passes through the deep inguinal ring, traverses the canal, and then it will exit through the superficial inguinal ring to insert into the labia majora. Another important structure associated with this canal in both the males and females is the ilioinguinal nerve. Now, what we need to remember is that this nerve does not traverse through the entire length of the inguinal canal. It enters the canal by piercing the internal oblique muscle and it exits via the superficial inguinal ring. So this is also a frequently tested point. Then we look at the deep and the superficial inguinal rings. The deep inguinal ring is an opening in the transversalis fascia. It lies above the midpoint of the inguinal ligament, and most importantly, it is lateral to the inferior epigastric vessels. This is a very important, frequently tested point. The superficial inguinal ring is a triangular opening in the external oblique aponeurosis, and it lies above and medial to the pubic tubercle. The relationship to the inferior epigastric vessels is key for differentiating various hernia types, and the inferior epigastric artery is derived from the external iliac artery, and the vein is from the external iliac vein. And it is important to note that these vessels lie medial to the deep inguinal ring, or the deep inguinal ring lies lateral to these vessels. The internal ring is situated lateral to the inferior epigastric arteries, and this is very important, and an image question is also put up for the exam, and this anatomy is very obviously understood by the surgeons, and here they will give you an image and ask you to identify the round ligament which is clearly seen passing through the deep inguinal ring. So we must know that the structure which is clearly seen on laparoscopy passing through the deep inguinal ring is the round ligament, or you may be given an image question and asked to identify the round ligament. Now let us see how the relationship to the inferior epigastric vessels is helpful in differentiating the various hernia types. So let us try and understand what is Hasselbalch's triangle, which is actually a weak area in the posterior wall of the inguinal canal. This triangle is bounded inferiorly by the inguinal ligament and laterally by the inferior epigastric vessels and medially by the lateral border of the rectus abdominis muscle. Now, the direct hernias, which are more commonly seen in older individuals, lie medial to these inferior epigastric vessels, and these will protrude through this Hasselbalch's triangle, and like we said, it is more commonly in the older individuals. The indirect inguinal hernia will lie lateral to the inferior epigastric vessels, and they enter the canal through the deep inguinal ring, and these are usually present in younger patients, and they may be congenital due to a patent processus vaginalis, and these will then extend into the scrotum or the labia. The femoral canal is actually lying a little lateral to the inguinal ligament, but it is medial and inferior to the femoral vessels. So here we can see the different types of hernias. So you can see that the direct hernia is lying medial to the inferior epigastric vessels. The indirect hernia is lying lateral to the inferior epigastric vessels, and the femoral hernia is inferior and medial to the femoral vessels. So let's talk about the inguinal ligament now. The inguinal ligament is nothing but the thickened and folded edge of the external oblique aponeurosis, and it is present in the upper end of the front of the thigh. It extends from the anterior superior iliac spine laterally to the pubic tubercle in a curved line, and it folds posteriorly. There is an opening called the saphenous opening, which is present inferior lateral to the medial end of the inguinal ligament, and it has a sharp lateral and inferior margin called the falciform margin. There is another ligament called the lacunar ligament, which is actually the medial fibers of the inguinal ligament and a few fibers from the fascia lata of the thigh. Another important structure or area that we are supposed to be aware about is the femoral triangle, which lies in the anterior superior third of the thigh, and it is a subfacial space that appears like a triangular depression inferior to the inguinal ligament. This depression is visible when the thigh is abducted, flexed, and laterally rotated. So the margins or the boundaries of the femoral triangle from lateral to medial side can be remembered by the mnemonic SAIL, S-A-I-L. So from lateral to medial side, it is the sartorius, the adductor longus, the inguinal ligament, and lateral and medial borders, they cross each other to form the tip of that triangle. Another important question is about the contents of the femoral triangle. Again, from lateral to medial, the mnemonic is navel, N-A-V-E-L. So that stands for the nerve, artery, vein, and there is an empty potential space which is present through which the lymphatics will pass. Another canal which is located in the same region is the femoral canal. It is actually located in the anterior thigh within the femoral triangle. And this actually you can think of it as a rectangular shaped compartment with 4 borders and an opening. So the medial border is the lacunar ligament, the lateral border is the vein, the femoral vein. Anteriorly it is bounded by the inguinal ligament, and the posterior border is formed by the pectineal ligament, the superior ramus of the pubic bone, and the pectineus muscle. The opening to the femoral canal is located at its superior border, and it is known as the femoral ring. This femoral ring is actually covered by a connective tissue layer, which is the femoral septum, and this septum is pierced by lymphatic vessels which exit the canal. The femoral sheath, now this is another structure. This is an extension of the transversalis and iliopsoas fascia, which encloses the proximal parts of the femoral vessels. So it is 3 to 4 centimeter inferior to the inguinal ligament, and it is subdivided into 3 compartments. So there is the lateral compartment containing the femoral artery, the intermediate compartment containing the femoral vein, and the medial compartment, which is actually where the femoral canal will lie. Now this femoral sheath does not enclose the femoral nerve. So the femoral nerve lies outside the femoral sheath. So again, this image is showing you the various placements of the various hernias on surface anatomy. And here we can see that the femoral hernia is below and lateral to the pubic tubercle, and the inguinal hernia is seen above and medial to it. So the key landmark for the femoral canal is the femoral vein. Now let's briefly touch upon the embryology part, which will help us tie everything together. So during development, the processus vaginalis is an outpouching of the peritoneum. In males, it normally gets obliterated except for the distal part here, which you can see in red, and that forms the tunica vaginalis. If this persists or it fails to obliterate, it leads to an indirect inguinal hernia. In females, the corresponding structure or the equivalent structure is called the canal of Nuck, and if this fails to obliterate, it can result in a hydrocele or an indirect inguinal hernia in the groin. And finally, let's go through some rapid examples which are important, and knowing these will more or less help you to understand the region and answer your questions in the exam. So the most common groin hernia in females is not the inguinal hernia, it is the femoral hernia. The ilo-inguinal nerve, it exits the superficial inguinal ring and it does not pass the deep inguinal ring. Direct inguinal hernias lie medial to the inferior epigastric vessels and are more commonly seen in older individuals. The indirect inguinal hernias are lateral to the inferior epigastric vessels and they pass through the deep inguinal ring. The congenital inguinal hernias or hernias presenting in the younger age group are most commonly indirect inguinal hernias. So let us go through a few questions which will help us to not only understand the topic better and also to recapitulate the entire topic. So a hernia sac lies lateral to the inferior epigastric vessels and enters the inguinal canal via the deep inguinal ring. So what is the most likely diagnosis? Is it A, direct inguinal hernia, B, indirect inguinal hernia, C, femoral hernia, D, obturator hernia, or E, incisional hernia? So just go back, in your mind and see, imagine the diagrams that we have gone through and what had we discussed. Try and answer before I move on to the answer screen. So yes, it is the indirect inguinal hernia which pass lateral to the inferior epigastric vessels and enter through the deep inguinal ring. The direct inguinal hernias are medial to the vessels. Which structure forms the posterior wall of the inguinal canal? Is it the external oblique aponeurosis? Is it the internal oblique muscle? Is it the transversalis fascia, inguinal ligament, or the rectus sheath? Now remember what the mnemonic was, and before we move on to the answering screen, keep the answer in your mind. It is the transversalis fascia. The posterior wall is formed by the transversalis fascia, and the medial end, it is reinforced by the conjoint tendon. So it was MALT, and posterior wall was the 2 T's in the MALT mnemonic. Which structure is found in the inguinal canal in females? Is it the ovarian ligament, the uterine artery, round ligament of uterus, genitofemoral nerve, or the inferior epigastric artery? So again, knowing the contents of the inguinal canal is important both for males and females. And before we move on to the answering screen, I hope you have your answer in your mind. The answer is, of course, round ligament of the uterus. So the structures through the inguinal canal, this is a very, very important question. And the round ligament of the uterus, it passes through the inguinal canal, exits via the superficial inguinal ring, and then attaches into the labia majora. The ilo-inguinal nerve is best described as passing through the deep inguinal ring. It is a content of the spermatic cord. It enters the canal by piercing the internal oblique. It exits via the femoral canal. It runs medial to the inferior epigastric vessels only. Again, answer in your mind. I'm moving on. The answer is, it enters the canal by piercing the internal oblique. This is a unique point and a frequently tested point in the exam. Finally, our last question. Failure in obliteration of the canal of Nuck in a female is most likely to result in a direct inguinal hernia, B, femoral hernia, C, hydrocele in the groin, D, obturator hernia, or E, umbilical hernia. So I'm sure a few of the points you've already omitted and you're not even considering them. So what is your answer? It is hydrocele in the groin. So we have studied that the canal of Nuck is the female equivalent of processus vaginalis, and failure to obliterate can result in hydrocele or an indirect hernia in the females. So thank you all for joining, and we really hope that this would be helpful for you, and all the best for your exam. Do well, keep studying, keep revising, and go to the exam with full confidence. We are sure you are going to do very well. All the best.